I'll get started and then perhaps hand it over to Emma to discuss some of the other details. This was a systematic review of how our clinicians within our Sarah Cannon Research Network are utilizing next generation sequencing in the treatment of breast cancer patients. And a couple of very interesting trends we're seeing just in how clinicians have adopted next generation sequencing tests for breast cancer patients over the years. And I think top line, we've seen an increase year over year of the adoption of next generation sequencing technologies in breast cancer. And 2019, our network sequenced about 1,000 patients or so. And an interesting bit there is the split between those clinicians that are using tissue-based sequencing and plasma-based testing. It has reached about 50-50 in 2019, which is an interesting advancement in and of itself. And I think we've got some interesting theories about why that's happening. Moreover, we wanted to really see if it was the same small group of physicians that were just ordering more and more tests year over year, or really if we were getting wider adoption of this technology. The short answer there is we're seeing both. More clinicians are ordering it, and the clinicians that are ordering it are ordering more of those tests, which is also pretty interesting. And a couple of other key characteristics here about the sort of physician trends that we're seeing, that we didn't see any change year over year in when in care these next generation sequencing tests were being performed. I think that's largely due to the fact that we've got great standard of care options for the majority of these patients, and clinicians looking for sort of the next line of therapy post standard of care is typically when these NGS tests are being ordered, and that can be several years after initial diagnosis. But the trend we were excited to see was that the time between when a patient gets a biopsy and when they get an NGS test, that time has shrunk year over year. And that indicates to us that clinicians are using fresh tissue, fresh biopsies to get this information for their patients, which we think is the right thing to do. We know that these tumors can evolve over time and through therapy. And so getting the freshest sample possible is always what we consider to be best practice. So that's been encouraging to see that as more of these tests get adopted, that time between biopsy and NGS test has decreased. I think, lastly, and I might hand it over to Dr. Sturgill to talk about this, the results for those were really interesting. We were able to break these out by histologic subtype breast cancer, so hormone receptor positive versus HER2 positive, and saw some really interesting findings there. And I might switch it over to Dr. Sturgill to talk through some of those for us.
Yeah, sure. Thanks, Andy. Happy to talk a little bit about what we actually saw in terms of trends in the genomic landscape that were uncovered with these NGS tests that have been ordered out in the community-based practices. I think it's important to note that molecular profiling in and of itself is not new for the breast cancer field. It's been around really for decades, but I think our technologies are just becoming more and more sophisticated to where we can pick up on more refined molecular changes that are happening within these tumors. So not only do we know if a certain protein is being expressed or not now, but with the advent of next generation sequencing, we can actually figure out are there specific activating or loss of function mutations within panels of hundreds of genes that can potentially inform therapeutic strategy. So with our patient population, we were actually able to dig into to their genomic profiles a bit, and we found some expected findings as well as some unexpected and interesting trends. Unexpected in the sense that they haven't been described before, And as Andy mentioned, we were able to assess this broken out by breast cancer patient subtype. So we found things like HER2 positive expressing tumors in the classical sense that they tested positive by IHC, often overexpressed the ERBB2 or the HER2 encoding gene. But we also found that HER2 negative cancers, those that don't overexpress the HER2 protein, about 6% of those patients carry a mutation in the HER2 gene that's actually activating. So that suggests a potential use for HER2 targeted therapies outside of that kind of classical case of HER2 overexpression. So you might have a cancer that's expressing normal amounts of the HER2 protein, but those proteins that are being expressed are locked in a constitutively active state, which could potentially warrant the use of HER2 targeted therapies in a case that we potentially had not really thought about. And we saw trends like this. We assessed over 60 genes, so there were a number of trends like that we saw across breast cancer subtypes, across different cellular pathways, DNA damage repair with the BRCA genes, receptor tyrosine kinase signaling, and others.